Hi everyone, and welcome to the Byolete podcast, the podcast where we discuss the science behind the brand. So welcome back to the podcast. We have missed a week, haven't we? We've had a lot going on, and we actually had a bereavement in the family, which wasn't the best. But the main thing is we're back. And behind the scenes with the actual business Byolete, things have been going well with that as well, haven't they?
Yeah, we've got a provisional launch date at the end of July. That says the 17th, but we'll take that with a pinch of salt. We might just move it back to first week of August anyway.
Yeah. So if anyone obviously wants to follow us on Instagram or any of our other socials, then please do. And obviously on YouTube, follow us along because we will be also putting out our weekly vlog. But anyway, the podcast this week. So before this, we actually had a podcast planned. So we were actually going to do the benefits and the risks actually of cold therapy on the cardiovascular system. And I was just scrolling through TikTok, as you do, and I came across this video. And the video was the top 10 prescribed drugs in the NHS for the year 2024 to 2025. And I just found it really interesting and thought, actually, I think we should do a video on this. And so here we are, and we're doing the podcast on that this week. So before we start, I did mention it to you briefly before, but you said that you forgot what the top 10 were. So I'm just going to ask you to name. Obviously, the top one was Atorvastatin, which you remembered. But other than that, can you name 3 other drugs that are in the top 10? Or what would you think?
Well, I remember Atorvastatin and Amlodipine. Apart from that, you said a PPI, so Lansoprazole and Omeprazole was up there.
Yeah.
You said Metformin.
Yeah.
You said Thyroxine.
Yeah.
Did you?
Yeah.
Were they the top 5?
No, they weren't, but we will go through them. So what we should do, I think, is start from 10, and I'll just say it. I'll say how many prescriptions were filed for the specific drug, and then I'll discuss how much it costs to the NHS.
And then we can go through maybe ways to reduce it, how it's being implicated.
Well, yeah, I think really from my point of view, I just wanted to highlight it, but once we go through them and we explain as to why, people are on these medications, it gives you a really good idea of how broken the system is. And when I say broken the system is, I mean in the sense that a lot of these medications are completely linked to lifestyle choices. And so when I say the system's broken, I mean the actual country is broken and the way that we live our life these days is broken. So number 10 was Sertraline. So Sertraline is an SSRI and it's used for the treatment of depression. So 24 million prescriptions were filed for that drug for that year, and it cost the NHS £52 million.
Okay, 52 million. I mean, a lot of people report, because it's also licensed for anxiety as well as depression, a lot of people would probably file that due to, I'd say, body image. I think obesity, overweight, I think that's a lot of, I mean, in the last 2-3 weeks, that's what I've been dealing with a lot with certain patients, is how they look.
Yeah.
And then going on to an SSRI or wanting to go on that. So 52 million, did you say?
It costs to the NHS.
Imagine how much like grassroots things, gym memberships, all these things that you could pile into communities to completely mitigate that. And then SSRIs, we don't even know how effective they are. And a lot of people don't have a good tolerability towards them. It takes 4 to 6 weeks to have any effect. And a lot of people don't really keep up with compliance or adherence.
Yeah, I actually had a patient this week who I think it must have been Monday, it was the beginning of the week, who'd just been started on sertraline, and she was feeling horrific. So there's a thing where we start a patient on an SSRI such as sertraline, and actually symptoms can get worse in the first 4 weeks before they get better, just basically due to the fact that your brain is sort of trying to rewire all the neurotransmitters within it. Again, like you say, we don't really know fully how they work. It's a bit of a grey area on the SSRIs, but this woman was actually feeling horrendous, and it was to the point where she was like, I don't feel like I could carry on taking this medication. So obviously we did discuss that, but I agree with you in terms of, a lot of it could be due to body image. I do think that, nowadays with social media, things are a lot different than they were, say, even 20 years ago. I think that does put a lot of pressure on people. Again, could be due to body image, but also looking at people's lives and thinking that people are doing a lot better than maybe you are. And I think that that is hard. However, we did a podcast, I don't know whether you remember this, and it was about gut health and how gut health is actually directly impacted on brain health. And so we know that if you have a diet that is highly processed, with ultra processed foods, then you can get what we call leaky gut. That can affect not only your immune system but also your mood as well. there's a direct link between the brain and the gut, and a lot of bacteria in the gut, if you feed it correctly, they do produce these neurotransmitters that do make us feel better. So yeah, totally, I agree that it's could be to do with body image, but I also think that it's also a
Yeah,
dysregulation
I don't think it's
due to the
solely
food
due to
system.
that,
Yeah,
but I think it's a big component of it. And like you said, financial pressures,
yeah,
all the other ideas that other people are so much better off than where they are currently. There's a lot of things going on.
yeah. So that's that one. I think, if I was to say to you, I think maybe each one of them, I'll say, do you think that it's mainly lifestyle driven, that why somebody would be on it? Would you say?
I mean, I've always had an unpopular opinion that anxiety, mental health, I think a lot of people do suffer with these things, but I just think a lot of it can be mitigated by how you deal with it yourself.
Yeah. I think there's a lot more research needed in order to actually determine whether it is to do with lifestyle, especially in terms of this gut brain axis. However, my thoughts is that I think that a lot of people who would be on that medication, it probably is down to lifestyle factors.
Well, one thing I want to point out anyway is the last 7 days I've not done any exercise due to a back spasm. I feel horrific.
Yeah.
And when people who are normally going on these medications, you always try and offer them this idea that they can improve exercise, mobility, all these things with the diet. And it's the last thing that they ever action because it does take a long time to see the benefits of exercise and all these other modalities we put in place. But the feeling that I get from doing exercise, I didn't even feel as though I was euphoric when I done exercise, but now
Yeah.
not doing it, I don't know how people actively choose not to. And I mean people that are physical and well abled,
Yeah.
and they just don't do it because it's hard, or they
You
just
haven't got
simply
time,
they
or
haven't got time,
yeah.
and all these things. They've got times to go and indulge in all the wrong things, in my opinion. But yeah, I don't know how people completely miss it out. But yeah, I think the majority of that can be preventative.
Yeah. Okay. So that's number 10. Number
Okay.
9, metformin. So in the year 2024 2025, there was 26 million prescriptions filed for metformin,
Okay.
and it cost the NHS 91 million pounds that year.
What percentage were due to PCOS?
So it didn't actually specify whether it was for type 2 diabetes, which is its main licensing and what the indication we use metformin for, but it can also, like you say, be used for PCOS.
I would say 95% would be diabetes.
I would say so. I think from where we work in Wigan, I think metformin whether it still is, was only a specialist's medication to be prescribed for PCOS.
Yeah, it still is, yeah.
So it's probably...
I actually don't think it's licensed.
No,
I
sorry.
think it's unlicensed.
Yeah,
Isn't
it is
for
unlicensed,
PCOS?
but when I say licensed, I mean in terms of a specialist has to prescribe.
I know what you mean, yeah. But I was just saying in general, I don't think it's
No, I don't
licensed,
think it is.
Even though it's used as a first line.
Yeah.
But in terms of diabetes, type 2 diabetes now, we've established in the majority of cases is reversible due to twin cycle theories that have been out since 2008. So in terms of why do more people now have type 2 diabetes, ultra processed food hike since the 1970s, lack of activity, immobility due to jobs, so many things. It's highly preventable. And if you actually do put in the work and effort, I mean, even when you go on the right medications, metformin being a key medication, you can reverse type 2 diabetes. I just think...
Yeah, I feel like there's really not much argument at all for that one.
No.
In terms of whether it is stemmed from lifestyle, because we know that type 2 diabetes in the overwhelming majority is caused by poor lifestyle choices.
I would say though, there are a few patients that I know of, and there are some case studies where lean individuals, such as yourself maybe, and your body's predisposed to storing fat within the pancreas, de-differentiating by beta cells, which means that they can't function, or you've got a genetic abnormality to insulin resistance, whatever it may be. So there are a very few select individuals, but as a whole.
Yeah, as a whole. I'd also say as well, I think sometimes they use it in type 1 diabetics to improve insulin sensitivity. So basically help insulin work better within the body. So, some of them prescriptions could have been due to that as well. Again, probably not even 1%, but yeah, I mean, was you surprised that was in the top 10? Based on obviously how often you see metformin?
No, you see it all the time.
Yeah,
I mean, the monitoring is still underperformed. there's still things that we don't do in primary care to monitor for metformin. So the amount of times I see it and have to react to all the monitoring, no, I wasn't surprised it was in there.
Yeah, no, I wasn't.
But I mean, I was going to say something earlier about the whole how this podcast ties in with the company,
Yeah.
and it's the fact that by the end of this, I mean, I don't know what else is on that list, but by the end of it, we're going to find out that the majority of these medications, the overwhelming majority, will be preventable via lifestyle. And if we can implement some form of testing, hopefully through our company, because we get a bit of money, but even if you just do it through a GP or some other form of company, you've then got this idea that you can act upon something and reduce the chance of, one, wasting the country's money, taxpayers' money.
What I will
probably
say,
go to something else though.
What I will say though is, obviously, when I say this is how much it costs, some people do pay for the prescriptions, so that's not cost the NHS that per se. Some people may have paid for them. However, I know what you mean in terms of, you know.
I'd like to see the stats as well to see how many people pay for prescriptions, because from my experience, I have is it over 60 still? It's free. It's actually amazing how little I know, because I don't deal community pharmacy anymore, but a lot of people were on benefits, so I was constantly giving them out without taking any payment.
But
that's another argument, another thing that I would go into in the future, but that's highly preventable. We offer a test on our panel. We do,
in order to sort of, we offer a couple of tests actually that could determine whether you're even predisposed to that, maybe 10-20 years before you even get it, in the context of type 2 diabetes.
And the ideal gold standard would be an oral glucose tolerance test, which is something we'd want to bring out if we had the capacity to do so.
But anyway, so that was number 9. Then coming in at number 8 is vitamin D. So that the amount of prescriptions that were filed last year was 28 million, and it cost the NHS, or it cost 108 million pounds worth of prescriptions were given out for vitamin D. I think this is a bit of a mixed one, in the sense that living in the UK, between the months of September and March, we don't actually get enough vitamin D from the sun in order to convert it in our skin. So sort of like, that's sort of a postcode lottery, if you like. And so I do get it from that side. But I also do think that it is also to do with lifestyle. So, if you're eating foods that are ultra processed foods, that most of the time void of vitamins and minerals and, things that are going to aid the absorption of vitamin D. So it's a bit of a mixed bag, I would say, that one. It would also be interesting to see how many of them prescriptions were treatment dose. So basically, when we're telling people to take vitamin D between the months of September and March because we don't get enough, that dose you can buy over the counter. And so we, as pharmacists working in general practice, would always tell our patients that you need to go and buy that.
Well, that's why I was surprised it was in there, because the shift for the NHS to tell people to go to buy vitamin D, but then seeing as though we've done a podcast that shows the average vitamin D preparation has 40 to 165% of the stated value, I would be inclined to give a pharmaceutical grade item if I had to prescribe it.
What I would say as well, though, is that I actually had my vitamin D checked a couple of weeks ago.
Yours was perfect.
And mine was perfect. Now, we have office-based jobs. We don't get out a lot. We're inside a lot of the time. So I would say that probably it is a testament to the diet that we do have, probably, because my vitamin D was fine.
Yeah, because the majority of vitamin D that we get from via the sun, it's like vitamin D3, isn't it, once it's activated, but within the diet, isn't it D2, calciferol? I don't know whether that's like 10% of what actually makes up your vitamin D in terms of input. It's interesting.
So I thought that was interesting. I think, if you eat more foods that are rich in vitamin D, so things like mushrooms, we eat a lot of mushrooms, so they've got, but again, it's one of those things. I feel like that one is probably on the fence, where it could be lifestyle related, but also it could just be that, unfortunately, we just live too north of the equator to actually get enough vitamin D. Would you agree with that one?
I would, yeah.
So then number 7 was Bisoprolol. So 30 million prescriptions were filed, and it cost the NHS, or it cost 26 million pounds. Again, with that one, the main indication.
I was going to say, think of the main indications. Go on.
So the main indication, really what we use it for now, is probably post-MI, so post-heart attack. Hypertension, so high blood pressure, not so much.
Very rarely. It's heart failure.
Heart failure.
We use it in, but again, heart failure and heart attack normally stem from something that's preventable. Very rarely, well, it still does happen, but you will get people who are more predisposed to having it. But there are instances for a lot of people that you can prevent them. So again, that's a medication, if you do test early on, you would never need to use.
Yeah. No, I agree.
It's so hard to see, but they are highly effective medication. If you've had a heart attack, especially within the 12 months after that initial period, it does improve the cardiac output,
Yeah.
which then reduces further cardiac muscle damage. At the 12-month mark, which we're poor at in the UK,
Yeah.
we can remove it if there's no evidence of heart failure.
Yeah.
But we still keep patients on it.
Yeah.
Again, it's not going to do anything in terms of harm, but they may get side effects from it. So, I don't know, peripheral, poor circulation to the peripheries, so cooling sensations, etc. But yeah, I just think, again, it's a medication that can be completely mitigated if you have a good lifestyle and metrics put in place years before that heart attack.
Yeah, I agree. Okay, so then number 6 was levothyroxine. So a thyroid replacement medication. 34 million prescriptions and it costs £51 million. I feel like this one's possibly the only one out of the whole list of the 10 that is, well, it's obviously an autoimmune disease. So hypothyroidism is caused by it's an autoimmune condition, isn't it?
In some instances, yeah, I mean,
Yeah.
very rarely is it like a lack of iodine within the diet.
Yeah. However, what I was thinking about was, we are only the amount of autoimmune conditions that people are getting nowadays are increasing, and there has been links that it has been caused by this ultra processed diet that we're having, which is causing things like leaky gut, which is causing bacterium to, pass through the intestine into the bloodstream and then attack our own cells. So for when people do get it, obviously, I don't think that it is diet related, but it's probably
It's the
there is
golden
a link.
ticket drug for a lot of people when they're putting on weight. The first blood test any person asks for is the thyroid, and they hope it's underactive because then they get the thyroid medication, metabolism increases, hopefully losing weight. I don't know the link too much, apart from iodine. Again, I don't really know many foods containing iodine off the top of my head.
So seaweed is a really good source. That's like probably the best source that I know of.
Okay, so I'm guessing East Asia
Yeah.
have got quite a good or a low thyroid incidence, I'm guessing.
Potentially, yeah, but I'm just thinking about sometimes genetically they're predisposed to other things, aren't they? I don't know whether autoimmune conditions is one of them.
But thyroid cancers are on the rise, especially within younger people. We used to work on a head and neck ward within Aintree in Liverpool, where you'd get a lot of thyroid surgery and then you'd have thyroid replacements because obviously you've removed it, along with calcium if you'd nicked the parathyroid gland. But I don't know the link conclusively between diet and thyroid enough to say whether it's preventable or not.
Yeah. I think for the time being, I think my stance on it is that it probably isn't preventable because it is an autoimmune condition. However, I think, again, more research would be needed because, like I say, there is some research out there that does suggest that autoimmune conditions are on the rise, and it could possibly be linked to the lifestyle and the diet that we do have these days.
Yeah, the only reason I want to look into it more is because you do have the odd person claim that they've beaten low thyroid through diet. And it's one thing that's always confused me. If it wasn't due to an iodine deficiency and it was autoimmune, for example, how have they managed to do that? Or was it wrongly diagnosed in the first place? Because for anyone who looks at thyroid bloods, you can have so many different diagnoses from one set. So you can have subclinical hypothyroidism. You can have normal free T4 and different TSH, euthyroid. It's all completely different. So whether it's being misdiagnosed in the first place, I don't know.
Potentially. Okay, so then number 5 was Ramipril. So 36 million prescriptions and that come to a total of £45 million. So Ramipril, primary indication would be hypertension, so high blood pressure in this case, but you can use it for heart failure prevention.
Yep.
Post heart attack.
Again.
Yeah. Trying to think, is there anything else that you could think of that it would be used for?
I mean, they're the top 3.
Yeah.
They're the top 3. Blood pressure is the main one.
Yeah.
especially if you meet certain characteristics such as diabetes of any type, or under the age of 55. There's all the algorithms and
Yeah.
schematics you've got to follow.
Yeah. But again,
But
we've discussed this in a previous podcast with hypertension. It is completely linked to diet and lifestyle
a
choices.
lot of them, yeah. Very
Very
rarely would you
rarely.
get like an
Yeah.
adrenal tumor, or would you the term essential hypertension is basically you've got blood pressure but we don't know what's caused it.
Yeah.
But yeah, normally it's due to lack of activity, increasing in age, salt.
Yeah.
They're the main ones, aren't they?
Yeah.
And then again, you've got heart failure and heart attack, same as bisoprolol. They stem back to the same things.
Yeah. So the number 4 and number 3, I'm going to do these together because they're both the same class of medication.
Okay.
And number 4 was Omeprazole, number 3 was Lansoprazole. So PPIs, so proton pump inhibitor medications used for the treatment of heartburn, dyspepsia. They can be used for other things. So they can be used for if you've got a stomach bleed, or if we're treating some bacteria that maybe was living within your stomach.
If we're protecting it against anti-inflammatories or steroids.
Yeah, or
but
things like
mainly,
aspirin. But mainly, like you're saying, what I see it used for is usually because people have got dyspepsia, is like the term for it, where they've got heartburn, or if they're using it alongside a medication that, such as aspirin, for instance, because they've had a previous heart attack or a stroke.
Or anti-inflammatories because the joints are hurting because they're not able to mobilise for whatever reason that may be. But in terms of PPIs as a class of medication, there's a lot of bad press around them for long-term use.
Yeah.
They've got links with osteoporosis. Again, these are only associations, not causations.
Yeah. Dementia, that's another one. Again, association.
You've got low B12, electrolyte disturbances such as magnesium, sodium.
I see sodium all the time. So a lot of patients who are on these medications are getting hyponatremia, which is low sodium. And that just throws up a whole host of different issues. The worst one being that you can go into a coma, or, and you can have seizures, become very tired. And so there's a lot, especially in the elderly, I see it all the time, where they'll go in and they'll have low sodium. So it's one of those medications that I think we historically have just prescribed because it was thought to be sort of a safe medication. And
it is an incredible medication. So if you are having a stomach bleed or you have excessive acid, they are so strong. They do work.
Yeah.
There's no doubt about it. But the issue is that once the treatment's completed, we don't seem to deprescribe it. People stay on it forever. But my issue is the main indication I see it for is reflux or dyspepsia, heartburn. And a lot of the people that I see and speak to, again, this is not generalization, this is from actual patients that I see. I'd say 8 to 9 out of 10 of them, it'll be they've got a poor diet, they're overweight, so increased abdominal pressure, which is going to lead to reflux. They've just got poor diet. Again, it's all to do with esophageal sphincter tone, leading to reflux. Again, all these issues can be prevented via good exercise regimes, whole food diets. It's a big cost.
Yeah. I was also going to say as well that if you're on these long term, they're obviously changing the pH of your gastrointestinal tract, which is going to affect your gut microbiome as well. And I think a lot of people don't really realise that they'll get put on a medication like that and think, oh, well, they don't get any side effects from it, so I must be fine. But long term, really, I always tell patients if they're going on it, I'll say you really should look at your lifestyle factors, by changing your diet, like you say, losing some weight, avoiding alcohol, avoiding caffeinated drinks, avoiding fizzy drinks, because you really don't want to be on them long term, because it does, with every medication there are side effects and long term effects. And I think that we probably will start to see I think there'll probably be a huge piece of work for this in the next couple of years for pharmacists and people in the NHS to try and deprescribe these drugs.
But this is the issue though. So they did want to deprescribe them to H2 receptor antagonists. So you've got ranitidine formerly, but famotidine. And then now the NHS have gone back towards PPIs, which is the complete opposite to what I would want to do. I'd want to be going to something that's less effective, but also less harmful from what I understand and remember from all the science. But I don't think people realise how strong it is as a drug. It completely removes the proton pump within your stomach, and your body needs to manufacture new ones, which is why if you were to stop it abruptly, you'd get over secretion and overproduction of it.
Yeah.
I was going to ask you, out of all the medication that you try and stop and deprescribe, which class of medication, that's sort of a leading question for me, which class of medication do you have the biggest issue with?
Historically, it would be painkillers, but I don't know.
I think these are actually my number one.
Yeah, they probably would be, but then I do tend to. I think the most important thing is to counsel a patient to say that you can't just stop it abruptly, because obviously whenever you are practicing as a pharmacist and any health professional, really, I think it's all about mitigating the risk, or explaining the risk to the patient, and then you can it aids concordance or adherence to the plan. And so I do now I do make sure that I explain to every patient, if they are going to stop it, I'll explain as to why I think they should stop it. Like we've just discussed, I'll explain all of the risks associated with it, but then I will put a plan in place to stop it, like maybe just have it every other day, then once 3 times a week, and etc. Do you know what I mean? So that it's they're weaning themselves off it.
Yeah, but I think I have the two issues that I've got with PPIs are that with painkillers, they're quite hard to get people off, but people know of bad cases of overdosing on painkillers. You've got, like, I don't know, all these big superstars that die through drug overdoses. You've never really heard of anyone die of an overdose of a proton pump inhibitor. And then the next thing is, with painkillers, hopefully a lot of the time it's just addiction as opposed to the pain still being present. Whereas with PPIs, the majority of the time they haven't changed their lifestyle, so that, the offending factor's still there. Spicy food, unhealthy processed food, lack of activity, obesity are still there. So when they come off it, they've still got the symptoms. So that's why I've got the issue with it.
I mean,
but again,
I
highly preventable.
Yeah. So just to finish that bit off, the combined total of how much they cost to the NHS, or how much it cost, was around about 160 million combined, which is a lot, isn't it? So actually it was like apart from the top one, which we'll go on to in a minute, it was the the third highest after vitamin D.
And what's the budget for the NHS?
I actually don't know.
Was it 200 billion?
Was it? Okay. So, I mean, even that's like the top 10 drugs, and obviously we know that there's thousands of medications that get prescribed, but okay. So number 2, Amlodipine, again, another blood pressure tablet. This one is a calcium channel blocker. So its sole use is really in hypertension. You wouldn't see it as much in heart failure because it can actually worsen it. You wouldn't see it post MI because it's contraindicated, actually, isn't it? Like in the first initial period. 40 million prescriptions for this in that year, and it cost £36 million. Again, blood pressure, highly preventable.
40 million prescriptions?
40 million prescriptions, yeah.
I mean, just for people to know, the first group of people that we start prescribing these for are over 55.
Yeah.
So over 55, 40 million.
Probably about
you're looking at 4 million people potentially on that.
Yeah.
Depending on quantities prescribed.
Well, yeah, that's what. Because it could be a month's prescription, it could be 2 months' prescription. Yeah.
Again, blood pressure, a lot of it is preventable. A lot of it's caused due to poor salt intake, lack of activity, obesity, alcohol intake. And then very rarely do you get essential hypertension or genetic forms of it, or pheochromocytomas and all these tumours, where very rarely. It's only if someone's under the age of 40 would we start looking into, why have you got blood pressure or high blood pressure under this age? Yeah.
And then coming in at number 1, we actually, a couple of weeks ago, ended up doing this ourselves, if you remember. So the America brought out its own top 10 drugs.
Oh, okay,
and we were playing along with it. I think, again, it was on TikTok, and we were saying, what do we think it was? America had very similar statistics, but it was actually different. I don't think PPIs were up there as high. Anyway, statin was the top one, and again, atorvastatin is the top.
That's one thing that we share with America, is cardiovascular disease is awful.
Yeah, I think in America, the top 5 drugs were, I think 4 of them were cardiovascular. If we look here,
we've got the statin.
3. Yeah.
Okay.
So similar to America, but it wasn't exactly the same. But yeah, so atorvastatin, the top drug prescribed, 73 million prescriptions, and it costs 110 million. So it's the most cost to the NHS, if you will.
I wonder how many people actually took it.
That is a good point. I actually said to you, so just a good story to tell. I had a patient this week he was actually only quite young, type 2 diabetes. I think he was about 45, something like that. Cholesterol was really high, and so he was started on Atorvastatin 20, which is usual protocol. Then he had his bloods checked 3 months after, so you get your cholesterol checked, aiming for a 40% reduction in your non-HDL cholesterol. His didn't change, and so I obviously hadn't seen this patient. He was a new patient to the surgery, so the GP was like, okay, well, we'll repeat it again, went over some lifestyle factors. He got lost to follow up and then ended up having his blood check again, and I think it was like 2 years later, and it actually stayed completely the same. I think it might have even got worse. And then instead of sort of going on over compliance, the GP then just increased it to 40. So he then got it checked again, and it didn't change. And so to me, in my head, I'm thinking, well, you would have seen some difference.
Yeah.
So this guy is clearly not taking this medication, but he's been getting it issued every single month. I tried to call him, I couldn't. So I'm going to follow him up this week to see what happened. But that was just an example of what we see in primary care.
It is. And people have a lot of negative outlooks and negative press towards statins.
Yeah.
Statins are incredibly useful. How they work, they are central. They are the rate limiting step within cholesterol synthesis within the body. But the thing is, if you ever look on social media, you'll see, oh, I went to the doctor today, cholesterol was high, and all they want to do is put me on statins. Well, I actually looked at 2 patients, and I told you about them the other day, in terms of 2 ended up having, one of them had a heart attack and one had a stroke. I think one of them was late 40s, the other was early 50s. And then if you looked 10 years before, they had a cholesterol test out the blue. I don't know why. It was raised. All the markers were all off. They had an intervention saying, would you like therapy here or would you like guidance? And the classic response that's always put in there is, patient would like to do it on their own, which is fine. I agree with that.
Yeah.
But then they had a follow-up, I think, another 3 years later. Nothing. It actually went worse, and they declined it. And the reason they declined it was something to do with family history with poor adherence to statins, or they didn't like the idea of it. And it's this idea that the only reason we use them in practice now is that's what we've got to deal with at that point.
Yeah.
At that point on a patient's journey, they are so effective to stopping it going any further. Ideally, we start them from 20, 15, 10 years old on, go and do a run, go and have this, don't do that. But that's why we've got to intervene with such radical treatments, but they are unbelievable.
Yeah.
There are links with a lot of people coming out at the moment saying about dementia. There's no primary study, or there's no study with a primary endpoint of dementia.
I think we did. Yeah, I mean, we are going to do a podcast.
We've looked into it, but at the moment, there's no categoric evidence to say statins increase dementia. If anything, you probably see a benefit because it's reducing the carotid artery build up of plaque.
Well, dementia is sometimes known as type 3 diabetes, isn't it? Because of the fact that it is cardiovascularly linked in that sense, because it's a build-up, like you say, of plaque within the arteries of the brain, which is stopping perfusion, basically, and killing cells off, sometimes, which is then leading to dementia. But
in terms of the statin use and need, so indication is normally primary prevention, so of cardiovascular disease. This is before you've had any cardiac event. Also secondary prevention. So once you've had an event, stroke, heart attack, peripheral vascular disease, whatever it may be. Genetic hypercholesterolemia, whether that be familial or just through poor diet, that's when we'd use a statin. So in a lot of these cases, lifestyle is, I say lifestyle, but exercise and diet are highly impactful on that. Very rarely will you get people where they've got an LDL cholesterol receptor abnormality or some form of genetic component where you would need therapy. Regardless of what you do with your diet and lifestyle, you will need input.
And just on that, at the moment the NHS can't actually test for that, but there is a specific biomarker called LPA, which is highly indicative of whether you do have a genetic abnormality, which you will need to be on medication, like you say, because diet and lifestyle alone is not going to change it. And it is actually a biomarker that we offer at Byolete.
It is.
Just to put that out there.
And the medication on offer, I don't think lowered it that much, to be honest. Even the most intense, I think it is going in a better direction. But
I think from what I heard, there was medications in the pipeline that actually are going to be specifically targeted for LPA, where they will, where they deal, I think it's like a nuclear where it'll like retranscribe the genetic information. Or
Well, we've got pretty good at ApoB. We can lower ApoB, but it's this LPA, which is a component of LDL cholesterol, which if you've got that, we need to treat you quickly, really.
But anyway, I thought this exercise was quite a good one because, like you said before, when we come to the end of it, we can see how many medications in this top 10 list are actually completely, or the majority is linked to what you do with your lifestyle. And I think I wanted to do this because I hate it for this population that we just think that it's normal to be on, all these medications. Like if I look at my parents, for instance, and you maybe look at yours, my dad's been on a blood pressure tablet, I probably for the last 10 years. So my dad's 56 now. So he's been on a blood pressure medication since he was 46. He was on a statin at the same time. So obviously he must have had some kind of high cholesterol. So for 10 years, he's been on that medication. It's just like normalized. And I think there is another way to live. Like you do not have to be on these medications. Obviously, we're not saying that nobody ever should be on medications. They have very specific indications. And after you've tried to mitigate everything through your diet and your lifestyle, and you still need a medication, then you still need a medication.
Yeah.
But it's this idea
But
that
the culture is that a lot of people take supplements, and some take 20, 30 a day. It's that idea of pill popping. Yeah, it's innate in the most part, but it's that idea, it's the culture of we've got something to solve that.
Yeah.
I mean, I said to my mum the other day, 20 years ago, you would dream about a drug that could make you lose weight without doing anything.
Yeah.
We're now in 2025 with a drug that can lose 22.5% of your initial weight just over a year without doing a single thing. You can do whatever you want and you will still lose a chunk of weight.
We're talking about Mounjaro here.
Mounjaro, by the way, yeah. But it's incredible. We are, and by the way, we're not stopping here. It's going into the 30s, 40%. By the sounds of it. But yeah, I think, we just need to, I always make the same point to you, is that when we make this podcast, if we go against what we're taught and what we're meant to convey, it makes it more powerful. So we've got degrees, we're prescribers in medication. I've been qualified for 8 years, you're coming up to 7 years. And that's what we do every day. We don't get any extra money, which is what I've heard recently from patients, again, directly to me on the phone. We don't get any extra money. If in an ideal world, every patient I see is on no medication, my job has no liability from a medical legal point of view. It's so much easier. I can just sign everyone off without even looking. So I want everyone to be on nothing.
And you would be treating sort of conditions, because I was actually going to go on to the fact that in that list, from what we've discussed, there was no medications that were for asthma, for instance, which is usually passed down in families. It's a genetic
the sad thing about that list is I'd say at least 70% of it is preventable.
I would probably say more, to be honest.
I would probably potentially say all of it, apart from the thyroid.
That would be the only one that you'd be like, oh.
That's the only one that stands out. But there's nothing on there that's also in terms of hereditary or, I don't know, like some forms of inflammatory bowel disease, asthma, all these things that you just said. They don't even make the list.
I know, although again, even that is a lot to do, there's evidence that could be possibly to do with lifestyle and stuff. But I think, again, they're not even on that list, and so they would be definitely things where you'd be like, oh, okay, well, your lifestyle could have affected it, but with the things that we've just discussed, out of the 10, like you say, 9 of them was it's more than likely going to have been some kind of poor lifestyle that has led that person to taking that drug. And I do think that it is sad, but I think it was really important to highlight, and I'm glad that we ended up stumbling across that video.
Completely out of the blue, unprepared, didn't have a clue what we were going to say, but one thing is, all their medications are highly effective in what they do. So
if you are taking any of them, don't just stop taking them.
That's what I was trying to make a point now, is that if you are taking them, they are highly effective in what they do. They've got really good evidence bases and outcomes. But the point is, it's assisting something that shouldn't really be happening in the first place. So if you've got high blood pressure through other means other than genetics that you can't really affect, I mean, being on a medication, it will come with side effects. It may come with, I don't know, like Bisoprolol, for example, with heart attacks, could come with impotence, could come with cold sensations to your extremities. It will assist your heart health, but ideally you should have done that without the need for pharmacotherapy. But we advocate, like you say, that if you do need it, you will need it. There's probably going to be a point that I need it. If I go into a hospital and I need antibiotics and all them things, there's billions of pounds are pumped into these companies. And I'm not against it. I'm just against the unnecessary prescribing of these medications when we've got an army of tools. More than ever now, sanitation, hygiene, food, exercise, all these things, we've got the most knowledge that we've ever had in our history and lifetime, and we use it less and less because it's more easy to indulge in medication. That was
but yeah, on that note,
ended on something else.
No, because I think it was good. I think I enjoyed doing this podcast. It was interesting. It was nice to have just a conversation completely off the cuff to see what we thought. And I know that we obviously think the same. We've done it for that many years now that like you say, you can come across harsh sometimes where you say things and you're like, oh yeah, that is definitely that type of patient. But when you see it on a daily basis and it's the same presentation, it's probably not coincidence, and
it's not coincidence. There's too many for it to not be due to something else.
Yeah, but I hope that some people watching this have taken something from it in the sense that, especially if you're not on any of these medications right now, where you have got the ability to actually change your lifestyle to not be on them in the future, then do it, because that's exactly what we're trying to do. Like you say, we probably will end up on some medication when we're older, because inevitably, as you do get older, things don't work the same as they do. But I want to give myself the best possible chance I can to not have to be on.
But if you go into a hospital and you require amlodipine to quickly reduce your blood pressure, don't reject it because you're saying, oh no, it's tablets. Like, actually do take it. It will work, and it's highly effective, especially under supervision. But I think that was a good podcast. Completely caught me off guard. But I think we look into cold and hot therapy over the next couple of weeks. Just because I need to know a bit more whether I should include it within my lifestyle. That's what I want to look into it for.
Cool. But if you got this far, then thank you so much for listening. If you haven't already, then please like and subscribe to the channel, because it really helps us. And comment down below if you're actually taking any of these medications, or you know somebody who's taken any of the medications, or even if you learned something. And if you do feel like somebody who may benefit from listening to this, then please send it to them. But as always, thanks for watching, and we'll catch you on the next one.